This podcast intro, songs AI. It's on YouTube and Spotify. You can use your ears or use your eyes. It's 30 minutes randomized.
Welcome back to another episode of 30 Minutes Randomized. I am excited because today one of my favorite people in clinical research has agreed to join me for half an hour. Luke Snedeker from West Clinical Research. Luke, welcome to the pod. Tell the people a little bit about yourself so they have some context for where your answers are coming from.
Hey, Steve. Thanks. Yeah, thanks for having me on. I'm honored to be here on your podcast and pumped for it. So thanks for the invite. So I'm Luke Snedeker. I'm the CEO of West Clinical Research. We're an independent clinical research site in Eastern North Carolina, doing general metabolic studies and kind of general health studies. My background is I actually started as a medical assistant in the industry and worked my way from medical assistant to research assistant, coordinator, and ultimately into operating a clinical research site before we decided to open up our own research site. So yeah, that's kind of where I started and where I've ended up. We've done basically all the different therapeutic areas of clinical research outside of oncology. There's oncology and everything else, right? We're in the everything else
Yeah.
pile. So
Awesome.
Yep.
You're living a very specific version of the American dream, subtitled Clinical Research Ascendancy.
Yeah. And totally
Cool.
fell into it and like hit myself. Like it hit me in the face when I slipped and fell one day. I didn't try to get into clinical research. My background's chemistry, and people are like, it's specifically ocean chemistry. So people are like, how'd you go ocean chemistry to clinical research? And I'm like, you'd be surprised how many similarities there are between blood and ocean water. It's just cells. So
It's all just cells. If you take nothing else away, folks, it's all just cells. So the way the show works, I'm going to hit a randomizer wheel. There's 8 questions. We might not get to all of them. Sometimes I might pull the thread on the question, and sometimes we might just move right on. So without further ado, I am going to pull up the wheel, and we're going to get started. All right. This is a category called unhinged corporate icebreakers. What is a life goal that you have that would disappoint your professional network to find out about?
I'm just gonna, for these, I just have to say the first thing that comes to mind. If I
You
start
have
thinking
to.
about it, I'll sit here quietly for 5 minutes. So the first thing that came to mind is a life goal of mine is to swim across our local sound in the middle of winter with no wetsuit on.
How far is the
Yeah,
local sound?
it's like half a mile. Yeah, yeah,
Do you plan to train, or you just one day you're just going to walk out there and do it?
yeah. It's probably gonna just be I'm sick of something else in my life and said I'm finally just gonna do this and just go do it. I'll
That's
have a safety
incredible.
boat. I'll have a safety boat. And
Safety boat.
I,
That
I,
seems.
I haven't figured out why that would disappoint my professional network, but it was the first thing that came to mind, so I had to say it.
I think maybe unnecessary risk. If you're going to do that, Luke, you should be raising money for cancer research also.
No. Mm-mm.
Maybe it
Maybe
doesn't
I just
disappoint
want to,
me.
yeah, I think I'm saving that one for when I just want to like feel something in my life, right? No. I'm just
Uh,
kidding.
no further questions. All right, let's go to the next one. All right. You are an independent research site at West Clinical Research in Eastern North Carolina. And I know that there's been a lot of hullabaloo in the last 5 to 10 years in the industry of consolidations and roll-ups. Do you view it as a headwind to be kind of out on your own?
Yeah, yeah, and I think how I would describe it is the industry was subsidized for a long time by what we call unicorn studies, which for small sites, especially like the smaller investigators that are embedded, things like that, or even small independent sites, those unicorn studies had a very high profit margin for them. They could put a lot of patients in fairly quickly with good budgets. And those are very much being scooped up and moved towards the consolidated networks because they have so much stronger BD programs going on. And I mean, they have a great case to make to sponsors too of, hey, when stroke of a pen, activate 20 sites instead of one. So with those unicorn studies being eaten up more, the smaller sites are kind of basically begging for scraps a lot of the time. And those budgets aren't as good. You can't put as many patients in. And so ultimately, there's not the subsidy anymore of that one good study you would get every year or every 2 years that kind of cushions you, pays for your coordinators, pays some overhead, things like that. There's a lot of scrap going on for more niche studies that don't pay as well. You don't put as many patients in, and it puts a lot of financial stress because you can't count on that one big study that's in the industry and going ahead and getting it. The networks are very much chasing those down and trying to get a stranglehold on them across their entire network, which kind of blocks out a lot of the individuals. And we'll see how that does in the industry. I mean, I think there's ramifications of that, and the sponsors should be careful because a lot of times it's the small independent sites that have some of these KOLs who just want their own little site. And ultimately, if they're not able to financially sustain themselves, where this has been subsidized by these unicorn studies before, and that's no longer there, the smaller niche kind of like exploratory programs or the rare disease stuff that doesn't have high budgets, there are rare diseases that have high budgets, I'm saying some of them don't, then they may not get done to the same degree that they were before
Yeah.
because there's not that subsidy from the larger phase 3 unicorn programs.
Okay, so I have two questions for follow up. I'm going to try and rush through them because I normally just want to keep spinning that wheel because I'm a gambler at heart. But first question: how common is this opinion, and how much of this is like Luke's point of view? Gut feeling.
Yeah, mm, gut feeling. I don't think it gets talked about a ton because
Okay.
I think a lot of the loud voices in the industry don't have incentive to talk about that thing in
Okay,
particular.
that's fair.
No, number two is there's a lot of nuance in this industry, and I think in public forums we talk about clinical research. In almost no context is the conversation of an industry of clinical research relevant. It almost everything needs to come down to therapeutic specific areas and business model specific context. And if you discuss there, like for me, my business model is a standalone clinical research site. We're independent, we're a single site. We've got a great team, and we do metabolic studies, cardiovascular. Um, we'll do vaccines if they come around. We'll do pain studies, and like we've got like our niche, and our contexts and like our opinions can be completely different with our experience being completely different from a group that's doing ophthalmology, right? That's in the exact same business model, different therapeutic area, completely
Totally
different
different.
perspectives.
Okay.
So we really need to add that context when we're having a conversation of like therapeutic area and your business model. Then we can have a conversation. Outside of that, it's going to be hard to really connect and have relevance.
Okay, that's fair. This is the only other thing that popped up as you were speaking the first time around. Is there a potential creation of this like negative selection bias where if these consolidated groups have a lot of leverage and bargaining power, they can look at three protocols and take the one that's most likely to enroll, and then the harder ones kind of get shifted out to sites that are maybe secondary or independent. And then because they're harder to enroll, it makes your metrics look worse. And then there's just kind of this negative flywheel. Is that a thing? That just occurred to me. If it's not, that's fine.
Yeah, I don't think so. I think most sites right now are actually going to take most of the protocols that come across their table.
Okay.
Um, so I don't, especially at the larger networks, they're I don't want to speak out of turn for them, but it's not common that a sponsor is going to say, "Yep, you can have this one protocol at all 12 of your sites or all 20 of your sites," right? And so what they'll do is they'll say, "Well, we're going to put this our favorite protocol at these sites. We're going to put this other protocol at these sites," and so they're going to try and take all of them no matter what. Just like any site wants, that's their business, right? They get the contract, and it's how you do the trial. It's how we ultimately pay our teams and make some money on top as well. Um, so I don't think that's an issue as much. I know I cherry pick studies all the time, not because I only want easy studies. Actually, usually it's the opposite. I want the harder, more complex studies that I can still enroll well in. That's a great place for us to be. We want studies that we can find the patients, we know we have the population, that we can do
Mm,
well for the sponsor, but also when they're easy, like easy, when I say easy, like not a ton of procedures, maybe not very complex. I think my coordinators get bored. I get bored. Not actually, no, it's not just that. It's more that we feel a lot of meaning when we're helping someone through a complex problem.
yeah, that makes sense.
Yeah.
I appreciate that. Thanks. All right. Well, that was great. Let's see if there's any more good questions hiding on the board. Okay. So I didn't want to type this entire question out, but there's been a lot of discourse online, and I've talked to you about this previously, about the difference between kind of activating patients from a database and kind of sourcing new folks through advertising or whatever method you have. I personally have been activated as a patient through a database, but it was a healthy vaccine trial. I've also responded to advertising. So I'm just curious, like, is one higher ROI than the other? Do you need both? Like, has that changed in the last 5 years? What's your take here?
Again, fully need to talk about context here, right? Because every therapeutic area and business model is going to work totally differently. In my space, and I'll talk about this first, my space, independent clinical research site, standalone. We do a kind of gen med studies, and we do both and find that local patients, like through advertising, has been a much lower barrier to getting people in the door than database. We have a dedicated recruitment team. We have a great setup for our social media campaigns and things like that. We can set up targeted campaigns for broad studies or broad therapeutics, or we can do targeted study specific campaigns. And when we run A/B tests, what it comes down to for us is that when someone is clicks an ad and says I'm interested, right? They've raised their hand and they've done the hard part for you, which is they said I'm interested in this. And then you have to figure out if they qualify, which is just a series of questions that they've already submitted and said, yes, I'm interested. The alternative, when you have a database, especially if it's like an EMR database where you're maybe partnered with a doctor, is that person hasn't raised their hand and said, I'm interested in clinical research typically, but they qualify. So you're getting a recruiter on the phone, and that can be a coordinator, a dedicated recruiter, or whoever, and basically going through the process of building trust to convince them to participate in clinical trials when they were not interested prior. That's a much harder conversation to have than I'm interested. Can you tell me if I qualify? So ultimately, for us, we do both. We run ads and then build a database off of those ads, and then we'll retouch the people who have expressed interest. That's still typically a
Yeah.
lower return on my recruiter's time than it is to just run a new ad and actually pull people in from a fresh lead off of a campaign.
Okay. Whoa,
So
whoa, whoa. Take me. Just say that again slowly for the people in the back. Can I just refer? You're saying like you're dropping all these people into a database. They're raising their hand saying I'm interested. If they don't qualify for a study right then, or maybe you fill up, or maybe they can't make it in the next month or whatever, they're traveling, but they are interested. You're not like leaving them out in the cold. They sit in kind of a CRM or whatever, and another study comes along, and you reach back out to them. The people who raised their hand X amount of weeks or months ago are harder to activate, and it's easier. It's better for you from an ROI perspective to just run a new ad.
yeah, yeah,
Huh.
yeah.
Do you think everyone feels the same way? Well, I know context. Like, I can't
No,
say this, but
no,
like,
no. I don't think anyone feels the same way. And that's
okay,
kind of one of the. I go to conferences sometimes and talk about it, and I get like this stare, like, "What are you talking about?" I'm like, "I don't know. I'm just telling you the numbers that we see." And why is that, right? Like, why? And I think that people go through different phases in their life, and right now people are getting bombarded on their phones and bombarded through email and bombarded with ads campaigns and all kinds of stuff. And dude, we just tune stuff out, man. And if it's been 4 weeks, or I mean sometimes 6 months since that person said I'm interested, that person's whole life circumstances could have changed.
absolutely,
And so
yeah,
if you're trying to reach back out to them and you might not already have like a warm channel of outreach, you're trying to reestablish that connection and get them interested again. Yeah, it's a lower barrier to entry than a total cold call, but it's still having to like reignite it. When you get someone that's like, boom, I click the ad, and then okay, we send them a text. Now there's a communication chain or a channel, and it's open and we're ready to roll. Like, that's the hard part, is getting attention, keeping it, and then like locking them in so that you can have the conversation about what the trial is, etc.
yeah, that's really
I
good.
think it just works.
All right, this is not on the wheel, but I gotta ask: like branding. How heavy are you branding stuff, West Clinical, and at what point do you want them to start understanding who you are and making that association?
Controversial question.
You
Um,
don't.
yeah.
I don't want to create controversy. I'm just
No,
curious
no,
how you're
no,
doing it.
no. I mean, first off, on like my image art, I don't put West Clinical at all. That's not what should be taking space on the ad.
Okay.
Both on any social media, it's going to have my little ticker up in the corner saying West Clinical is running this ad, right? Like, so I don't need that on the actual image. That's not what's going to make someone click the ad. Vast majority of our patients are first timers. Um, like, so they don't know who we are. They don't really care. Our reputation isn't what's important here. I think the first conversation is education, building trust, and ultimately like creating a frictionless environment for going through the process. I really don't think that sponsor specific brand ads work super well either. I don't think the patients care if you put a special name on the study. They want to know, what is the indication? Is it relevant to me? And then what are the FAQs about what this means to dive into it? It needs to look professional. It can't look like it needs to look professional. That builds trust. It needs to look like the process needs to be frictionless and needs to be like actually take them into consideration. You can't put a whole form with 30 questions on a phone. Like, don't make someone go through that. It needs to like step by step take them through a journey. Um, and those are the things that matter that we've found. Um,
Yeah, that's totally
what's
fair.
funny is there's so many people that are doing ads right now. Like, obviously it's working for plenty of people. I just know that what how we do it has worked very cheaply. And I think that's because we fine tune so much here and there about the patient's journey through the process and taking them into consideration. So yeah,
Yeah, that
that's what we do.
tracks. And I'll say, as like an old marketing head from my former career, there's plenty of reasons that branding could work and be meaningful outside of getting someone into the funnel. So like downstream, or I'm talking about like, sponsor branding or naming the study a certain thing. Like there's plenty of reasons that could be helpful. I just, from a straight like, will it make the person respond to the ad better? It's tough for me to believe that. Although there's plenty of people out there who say it does. Cool.
I,
All we have are
so
opinions and conversations.
my thoughts on that are most of these studies start and stop in a matter of months. It's like in terms of recruitment, like enrollment is sometimes a matter of 2 months, 3 months, maybe a year, sometimes a year and a half. That's a pretty short amount of time to build a brand and like get it like in the general public perception of what a brand is and why it should build trust and all those things. So I think
Yeah,
it's way
for
easier
sure.
just to put a relevant ad in front of someone that makes them stop scrolling, gives them the information they need, and then starts jump starts them through the process. Like that,
Yeah.
it works well
I
enough. The algorithms are good. Let them
I
let
think
them
the
let them
most
work.
elite study branding of all time would still get trounced by a fantastic experience at the local research site. If you walk in and have that good experience, it feels warm, you feel welcome, your questions are answered, treated like a human being, and you walk out of there feeling like that was worth my time. You're coming back, whether or not it's got the right color palette and a cool name. I don't think those things hurt, but I just don't think they help as much as like boots on the ground human
Yep.
experience. Cool. All
Uh,
right. Thanks, man.
a, so a lot of this is a little different, but it's relevant to what you just said. A lot of how we operate is, where can I do the biggest lift? We only have so much bandwidth, and our teams in clinical research, you have to keep your teams pretty tight because studies go up and down, so you can't have a ton of overhead. We always are looking for, yeah, we can improve things in 10 different places, but which one's going to give us the biggest improvement? And that's what we try to focus our time on.
Cool. That makes total sense. All right. Here we go. Back to the wheel. I love the little ding. Ooh. Um, this can just be a no if you don't, but do you have an eSource horror story?
Of course. Of course we have eSource horror stories. I've been using eSource since 2018. Actually, before that, we've been using a dedicated clinical research eSource since 2018. Prior to that, we used an EMR, and that was a mess. So I don't ever recommend anyone to do that. Um, but eSource horror story, yeah, we built. Um, it was the classic birth date issue where we put in birth dates and the numbers rounded, and they rounded I think up in age instead of down. So it was saying that everyone was older by a year than they were supposed to be, which wasn't an issue, except that we excluded patients who shouldn't have been, or like it was a
Oh,
whole it
wow.
was like
Yeah.
we didn't it was is a pain. Anyways, always double check your formulas and how they round in eSource, and then
Perfect.
standardize them across everyone that's building source.
That sounds great. It just reminds me of the Office Space. Like I missed some minute detail, like a tenth of a
Hmm.
decimal, and yeah, it's great. Cool. All right, that was a quick one. We're back on time. We got four more left on the wheel. Let's see. All right, this is the last like real interview question, and feel free to go as deep here as you want to or not. But I know that you are tech forward, like you are thinking about these things all the time, but you're also practical. So, what is the tech stack that you guys are running?
Yeah. Hmm.
You don't have to name names. You can just say, "Here's like the
No,
thing we have." If it's
no,
like
it's
a
fine.
functional, okay.
No, I mean we use Creo for our eSource, CTMS, eReg. We use Stitch for our participant engagement, making sure the patients show up, stopping our no-shows, our e-diary reminders, and we have an incredible e-diary compliance rate. I couldn't believe it. I mean, we're on some big vaccine studies in our they have weekly diaries for 2 years, and our compliance rate's like 94%. And the sponsors, what are you doing? Oh, well, just send them a reminder every once in a while. It's pretty easy. It's all automated. I don't even think about it. Um, so Creo's great. Creo's allowed our site to scale bigger than we ever could have otherwise. Stitch is fantastic, gets our patients in the door, keeps our diary compliance metrics good. Takes a lot of, I mean, I basically got rid of a position that didn't fire them. They got moved to a different role, but their whole job changed when we started with Stitch. Um, we use Google Workspace because it's better than Outlook, um, better than Microsoft. We're still on all PCs though. We're not on Macs. Um,
You're not going to
what
get any
else?
shade from me there.
Yeah, and then we've filled the gaps with stuff that we're building ourselves. So straight up Claude code, and we've purpose built specific workflows for ourselves that none of these other groups are building for us, and that has been a huge game changer. It's really cool. We do it in all the different areas outside of what like a Part 11 compliance would be required just for simplicity's sake right now. But in terms of like dashboards, workflow automators, learning management systems, like all that kind of stuff, super easy. You can set it up, dive in for a week, tell it you don't know anything, and it'll teach you how to do it all.
How much of you is like, oh, now we're gonna scale this and monetize it and sell it to other sites?
I looked at it, it's not worth it anymore, man. Like there's why would I do that when I could if I could sit down and learn to do it in like 2 or 3 weeks myself, that means anyone can, right? So why would I do that and then put a bunch of time and effort into selling it to someone else if they can just go out and build the same thing? So
The
I'm not a tech,
counterpoint
yeah.
is I grilled a hamburger over the weekend, but
Hmm.
like McDonald's isn't worried about it. So I don't know. Home bread makers have been around for 100 years, and people still buy it at the grocery store. There's going to be some SaaS that is absolutely worth it,
But
and
yeah,
some that's absolutely not. And I guess that is what we're going to see play out over the next
th
5 years.
they're going to be the ones that have something that's like a differentiator. And the thing is that the baseline has changed. The baseline of SaaS used to be you built something and it can like have dashboards and do some workflows, right?
Hmm.
That is literally anyone can build it in a weekend now. If you need something that's multi-site, scalable, different permissions, different levels of access, add modules, like a PHI database and a HIPAA compliant database, like that's when you need a professional that comes in and builds something like that's scalable and is very much very robust and like good. If you're just building something that's like, oh, for my team of 20 or 30 people, and I need it to represent when a patient flows through the clinic appropriately, right? Like, it's super easy. You can do that without PHI. You can do that in a way that doesn't compromise anything. And it's basically just a visualization for your whole team to see, like, one step by step how someone's moving through your office. What room are they in? Where are they? How long were they there? Things like that. So, like, I, but is there something I could monetize? Maybe. Um, I'm not a I'm not a SaaS person. We love being a clinical research site, and we're just going to keep doing what we're good
All
at.
right, there you go. Cool, man. Well, one of these questions is about how you're using AI, so that'll be pretty short. But this is a more fun one. All right. What was the
Ticketed
last
event.
ticketed event that you went to?
Ticketed event. Other than a conference, um,
Yeah.
yeah. Other than a conference, oh man, what? That's not
I
good.
mean, I know you just had a baby, so you're not getting out a ton,
Yeah,
like
yeah, yeah,
movies,
yeah.
music, live theater.
Live theater. Um, we did a live theater in London, and yeah, last December we saw Annie. It was pretty cool.
All right.
Yeah,
A little twist on.
yeah, a little
Were
twist.
they British orphans? Did they change the whole show, or no? It was still.
I don't know. Anyways,
Okay.
anyways, that was good though. Yeah.
Yeah, I'm a big fan of live theater. All right, we have two left. We might finish our 30 minutes. Okay, you mentioned conferences a couple times. We may stay here for a second, but I wanted to know. I'm going to ask a couple questions and just name the first conference that pops in mind. You're not denouncing other conferences. I don't even know what conferences you've been to, so don't feel any shame here.
Yeah.
If you had to get an ROI out of a conference, you can only go to one the whole year. Which one are you going to?
SCRS.
SCRS,
Yeah, the
Global
Site
Site
Summit
Summit,
Solutions. Yeah, Global Site Summit.
Orlando
Yep.
407 represents.
Yep.
How many times have you gone to that?
Every year since probably 2019,
Okay,
maybe
and
2020,
you're
20, somewhere in there. I can't remember with
sure.
COVID, somewhere in there.
Yeah,
Yeah,
I deleted 3 years of my own memories,
same.
so it's fine.
Yeah.
Okay, if you are going to a conference and you want to learn something new, you don't want to hear the same. You're like, I want to go and I want to hear something that
No,
challenges my thinking.
that's also going to be SCRS. Yeah, the same one. Yeah, that's gonna be a boring
All right.
answer. Yeah.
Well, we're now all we're doing is filming commercial for SCRS.
Nah. I mean,
The,
you can ask me different questions and I might answer different conferences. Those are just those
listen,
two in particular.
don't impugn me as a podcast host. I'm just starting out. These questions are off the top of my head. All right. I was gonna ask vibes, like best vibes at a conference. Like you just go and you're gonna see the people. It's gonna be SCRS again
It's also going to be
because it's all
SCRS.
your
Yeah.
homies. Okay.
Yeah, sites. I mean, if you want to ask like, what conference are you going to go to that is like you're going to go get a study for your site? I would say it's Scope in February. Scope in
Well, so
Orlando.
that was kind of my ROI question. Like, if you knew you had to win a study, you
Uh,
would pick Scope over SCRS.
if I specifically only had to win a study, I would pick Scope over SCRS. But in terms of ROI, though, I get way more out of SCRS than I do out of
Oh,
Scope. Yeah, they're different.
walk me through the difference between winning a study and overall ROI for you as a.
Com Coming away with new general connections. I mean, so let's say if I go to SCRS and I meet 10 site operators. And then over the course of the next year, from those 10 site operators, we have, two conversations each. And from those, I learn about 5 studies and I get 2 or 3 studies, right? Or I learn about a new ops model, or learn about a new tool or a vendor or something that they're using that's working well, or I learn about a new, pay structure for their coordinators. By all means, like that's the kind of conversations that you
Okay,
have. Though that ROI to me is a lot bigger than going to scope and winning one study. Like,
fair
sure,
enough.
going to scope and winning one study is a big deal. Like, you spend a lot of money to go to that conference and do the meetings and get it done. And there's operations stuff there too that is good. And there's a lot of industry specific info that's good. But I go to SCRS because the people that are there are some of the best in the industry, and I want to talk to them, give my opinions, get their opinions, and then ultimately come away with like a 1 + 1 = 3, right? Like we talked together and came away with a better overall outcome together because we had that conversation. And that's way more ROI than winning a study that I just have to go back the next year to win another one. Like it's basically compounding interest versus like a one-time payment.
Unfortunately, I'm not going to release this podcast unless they pay me now.
Fair.
So
All right.
that's a bummer, but
Okay, yeah,
no,
that's
I
fair.
really appreciate it. I've gone to SCRS a few times, and it's always been a really good experience. Even as someone who I was going as a vendor in the space, a solution provider. People hate the word vendor. Okay, I'm curious, and I'm asking this to everyone I can right now. Um, AI, whatever. How are you using it in your day to day? Not necessarily how West Clinical is using it, because you gave us some answers there, but how are you, like, what are you opening almost every day? And like, what are you doing it with it?
I'm a heavy Claude user. So, um, and I'll say I use it for as much as I can outside of anything that contains PHI or requires HIPAA compliance, and outside of anything that requires Part 11 compliance or anything that has confidentiality issues with any CDAs that we sign and confidential documents. And there's ways to do that, right? And that's like where you have to get a little bit subtle. In my personal just work, we can use Cowork. You can set up the different workflows. Like we do something called a collective collaboration with the team. And what I've done is essentially built out a workflow where I have a series of a few dozen different questions every couple weeks. And it basically like prompts that question, puts it in an email for me, sends it out to the team. They all respond through a Google form. I get to basically grade all their responses. It's like a learning moment. And then I learn from them, like, how are you guys handling situations like this? And then that comes back. I get to prompt it and I put it in, and then I come up with the answer that I think I want to be correct. And I send that out as a standardized, like, hey, when you come to this situation in the future, this is how it goes. And that's all just automated, right? And that piece is just one example of like how you can use some of these tools so that you don't want it to be your brain, right? You want it to be an extension of yourself, so that like it's my head coming up with the questions, but now instead of it taking an hour and a half to like build all this stuff together, it just like does it for you and sends it out and then compiles it when it comes back. Cool. I don't do a lot of image generation. It's not really what I want to use it for. I use Canva for my image generation. I use it to summarize things. You can dive into having like a locked environment either through Amazon or through Google, and then use AI. And that's when you can start playing with things that are a little more like confidential, because
Sure.
you actually put the
Yeah.
right documentation in place so that it's not training models and going outside of your organization. And like that's when it becomes a really powerful tool in clinical research, right? You're like, okay, how can I take this information, digest it down into something very simple very quickly, dispense it to my team, or do proofs on specific aspects of what you're doing. And I'd say I'm a heavy Claude user. I've got the max 20 plan, and the biggest thing that I use with it though is coding. I can build any little tool for our team in a couple days, and so we basically just have the team. They tell me a problem, and I'm like, this is how I'm thinking about solving it. And if they say yeah, I just build it and I give it to them. And then after a couple of weeks, I basically act like I'm going to take it away. And if they're mad about me taking it away, I know it's working, and we keep using it.
That is
Yeah,
awesome.
that's like the best thing is, oh, it went down for an hour and everyone's complaining. That's perfect. That means they're actually using it, and then you keep it out there.
That in itself is a really interesting takeaway. Man, all right. Thank you so much, Luke. We are at 30 minutes. I had a great time talking to you, and I think there's a lot of stuff in here that people can use. Any parting shots? Otherwise, I'm just going to like cut off the recording and go our separate ways.
Take the context of your indications and your business models. We can all communicate better if we understand that. I see on LinkedIn all the time a ton of different discourse that just people not understanding what each other is saying and trying to say that person's wrong, this person's wrong. And it's like, actually, I've seen where both of you guys are right. You're just working in different worlds. Yeah, you're in clinical research, different worlds. So we should start all of our conversations with the context that we're giving our experience from, because they are drastically different, even next door to your clinical research neighbor.
That's really good. I will do my best to introduce context. Thank you so much, man, and look forward to seeing the cool stuff that you come out with in the coming weeks and months.
Thanks, Steve.
All right, cheers.
30 minutes randomized.
Thanks for listening to 30 Minutes Randomized. If you enjoyed the show, please feel free to like, subscribe, review, or share it with a friend. Until next time, I'm your host, Steve Wimmer, reminding you to stay random.